History of presenting illness. History of loose stools for the past 3 days. Large in quantity, watery, 4 to 5 episodes per day. Not bloody or mucus, not foul smelling, not frothy, non-sticky, not related to feed. History of fever for the past 2 days. Low grade, intermittent, not associated with chills or rigor. No aggravating factor, relieved by medication. History of decreased urine output since morning. Last voided 5 years ago. High colored urine present. History of refusal of treats present for the past 2 days. No history of vomiting or regurgitation of feeds or swallowing difficulty. No history of
Past that.
Ma'am?
What is that history for? History of vomiting or regurgitation of feeds?
Regurgitation of feeds to rule out any congenital anomalies like cleft palate, cleft lip, which may lead to recurrent aspiration episodes and malnutrition, pneumonia.
Why did you ask for
malnutrition.
this history? You're asking for an acute symptom. That is 1 day history of 2 days history of diarrhea and fever.
It can also occur in cerebral palsy.
Why are you thinking of cerebral palsy in this child? The child was cerebral palsy, the history of the mother would have been different. No? So, in a case of SAM, usually the mother will be bringing this child for the acute complaint, but try to bring the history of child not gaining weight as compared to his siblings or his peers, something like that in the breastfeeding complaints itself, so that you can ask all these relevant history to rule out other comorbidities or etiologies. Otherwise, this child is only breastfeeding with an acute history of fever and diarrhea. I'm really not bothered why the child has regurgitation of feeds or swallowing difficulties. But in usually SAM children, the mother will be coming for an acute history. He'll be picking up SAM. That is the usual scenario. But once you bring it to the breastfeeding history, it will be easy for you to go through this usual protocol. Why you ask for swallowing difficulties?
Any nasopharyngeal, any pharyngeal muscle incoordination which can occur in cerebral palsy, which can lead to recurrent aspiration.
Even in an acute case of SAM, you're usually not thinking about any underlying etiology. It's purely a nutritional case that's going to be presented. So don't bring in all these history like swallowing difficulties or maybe regression of feeds can be there, can be important history, but swallowing difficulty is a little far-fetched.
Okay. No history of abdominal pain or distension. No history of any incision.
Why did you ask that? What can cause abdominal pain or distension?
Abdominal distension can occur due to hypotonia, due to hypokalemia, which can occur due to dyselectrolytemia in SAM babies.
But what can otherwise also cause abdominal distension in a child with
due to ascites, edema, ascites.
Yeah.
Hepatomegaly.
Hepatomegaly to cause abdominal distension. That amount of hepatomegaly is usually not seen. The more important cause will be protein malnutrition. Protein deficiency itself will cause hypotonia and can cause a protuberant abdomen. Of course, hypokalemia is an important cause, and if the child had ascites, then that will become an important cause. Okay. What if the child had abdominal pain?
Infective causes of diarrhea can be associated
with abdominal pain. Which infective cause can present with abdominal pain?
Maybe some acute abdomen like intussusception can.
Thinking about intussusception, then you can think about abdominal pain as a history. Otherwise, no infective diarrhea will be presenting with acute abdominal pain.
Okay.
Yeah, go on.
No history of incessant cry or cry during maturation. No history of cough, cold, or breathing difficulty. No history of recurrent respiratory tract infection. No history of succus.
What will be your inference if the child had incessant cry?
Maybe it can occur in meningitis or any infection in infant can present with incessant cry.
So it is usually a sign of meningitis or more commonly a sign of acute otitis media. So don't combine that history with crying during menstruation.
Okay. No history of succus cycle, forehead setting, or increased precordial activity. No history of seizures. No history of polyuria or polydipsia. No history of skin rash, ulcers, or ear discharge.
What other acute history would you like to ask? The child is coming with diarrhea and fever. What other acute history you want to ask? Urine output. That can, you said about urine output. What other history can help you to grade the degree of dehydration?
Thirst.
It's the
Whether
third. So that should come in your initial history itself. That is, you talked about oliguria. You also give a history of how the child drinks fluids, whether the child is able to drink fluid or is refusing fluids and all that. Okay.
Okay.
That will be a more important history. Okay.
No history of skin rash, ulcers, or ear discharge. No history of passing warm and stool. No history of jaundice. No history suggestive of vitamin
Why
A
jaundice?
deficiency. To rule out any liver disease like neonatal cholestasis.
Why are you bothered about that in this case? Again, it
Again.
starts with a history. If you had told me the child was not gaining weight, then we can go through all these. We'll assume that the child had not gained weight. Sir is telling too much negative history. You have to give, so in SAM, you just remember, you have to bring that history in the initial presenting complaints. The child is not gaining weight. And from when did the mother noticed that the child was not gaining weight? If you bring that history in your presenting complaints, then we can go to the probable causes of not gaining weight, the other causes of vitamin deficiency or micronutrient deficiencies. We can go through each one of them. Okay. So this looks a little, and don't jump from one history to other. You first finish off the etiologies of severe acute malnutrition. Second, you go into maybe before that you can go into features of micronutrient deficiency. You're jumping from one to other. Okay. History of passing worms and stools. What is the relevance of that history?
Worm infestation can lead to iron deficiency anemia.
And then only that? If there is massive ascariasis, what else it can cause?
Can lead to malnutrition, defective food intake.
Malabsorption. It can lead to malabsorption and subsequent nutritional deficiency. I think jaundice is not an relevant history, even if it's you get brought the history of severe acute malnutrition. What history you asked for vitamin A deficiency?
If it's child is not actively looking at the mother at night, symptoms of night blindness or any conjunctival or corneal drying or discoloration noticed discoloration noticed by mother.
They are not noticed by mother. So you can ask frequent falls. You can ask history of frequent falls, especially during the evenings, which the mother might maybe it will be a leading question for night blindness. Okay. Otherwise, if the mother had recognized the child was not having vision in the night, that would be her primary complaint. So history of frequent falls during the evenings or when there is less light or during the dark areas is the history for vitamin A deficiency. Suppose a child had bleeding manifestation, what will you think of in a child with SAM?
Vitamin K deficiency.
Then?
Any liver abnormality leading to altered coagulation profile leading to.
In this case, SAM is, we are talking about nutritional SAM. Other than vitamin K, what other vitamin can present with bleeding gums?
Vitamin C.
Vitamin C. So for both of them, it can be a history. Okay. So go on.
No history of bony deformities, no history of poor wound healing, and no history
What
of
is
delayed
that history for?
Poor wound healing, ma'am.
Yeah.
Vitamin C deficiency.
Okay, so vitamin C deficiency, more of bleeding gums and joint pains. That will be the history of a vitamin C deficiency. When it was history of delayed milestones?
In severe malnutrition children, there may be decreased muscle mass and there may be a delay in motor milestones.
Okay. What other milestone can be lost in a child with SAM other than your lost motor?
Social.
Social. Right. So that history can also be asked, or it can be an examination finding. So, okay, go on.
Past history.
Any other history? Any other micronutrient history you should ask for? You asked for vitamin A, D, E, E not a K. Asked for vitamin C. Then what history you ask for? Iron deficiency. For iron deficiency.
Lethargy, easy fatigability.
Easy fatigability then. Extreme pallor can also be in history. The mother herself or the grandparents will notice the pallor or history of pica. Both will be history of iron deficiency. Another important history is B12 deficiency. So history of
Neurological.
not in the history you can ask for knuckle pigmentation or generalized pigmentation, increase in pigmentation, all that. So include B12 as well as iron deficiency in your history.
Okay. Past history, history of similar illness, diarrhea at 4 months and 6 months of age, treated with oral medications at ORS at a nearby hospital on an OPD basis, each episode lasting for about 4 days. No history of febrile seizures, congenital heart disease or thyroid disorder. No history of any chronic cough fever with rash or coryza. No history of previous hospitalization.
What do you think is the type of diarrhea in this child? Is it osmotic or it is secretory diarrhea? So the
Secretory,
history, how did you find out it was secretory? You should say some more history for secretory.
large in quantity,
Large,
watery,
but it was watery.
watery diarrhea, large in quantity. It's not related to feed intake. Starvation does not decrease the episodes of diarrhea, not associated with any blood or mucus.
Starvation, you should talk about overnight, whether the diarrhea stops overnight or not. And can be foul smelling and can sometimes even cause perineal excoriation. So this you're telling theory, but it should come in your history so that we can differentiate whether it is a secretory or osmotic diarrhea. Which is more common, secretory or osmotic diarrhea?
Osmotic diarrhea.
Right?
Rotavirus is the most common cause. It can cause both osmotic and secretory, but osmotic is the most common.
So what can cause secretory diarrhea?
Any other infections like viral infections like rotavirus, Norwalk, adenovirus.
Rotavirus is predominantly osmotic diarrhea. Those that produce toxins,
E. coli, enterotoxigenic E. coli.
Or cholera, all these can secretory diarrhea, which are less common. So only osmotic diarrhea is about. So, or it can it be a manifestation of primary immunodeficiency?
But the each episode lasts for only around 4. It is only an acute diarrhea, not a chronic diarrhea.
So there are only 2 episodes. Okay.
Only 2. Any other manifestations of primary immunodeficiency was not there. And usually immunodeficiency is manifested with growth retardation, abdominal distension, malabsorption. Any other features of immunodeficiency as such is not there. Only diarrhea.
First thing, it will be multi-system. It won't involve only one system. Okay. So you have to ask if it is multi-systems, there was a ear discharge or there was an I'll be thinking about immunodeficiency. If it is involving only the GIT, there was suppose the child had recurrent episodes of GIT, what other differential diagnosis you'd be thinking of?
Other causes of immunodeficiency like HIV should be ruled out.
Immunodeficiency will present with multi-system involvement. If the child presents with only recurrent diarrhea, probably several
lactose intolerance.
Intolerance, something that has produced severe acute malnutrition in the child. Child who has recurrent diarrheas, producing severe failure to thrive or growth retardation. What can be the other causes? Suppose the child is coming from North India or from Andhra or Karnataka, what will it be? Severe growth stunting, recurrent diarrheas, or sometimes constipation alternating, iron deficiency, which is not responding to your iron therapy. What is the differential diagnosis?
Malabsorption syndrome, celiac disease.
Celiac disease. So it could be a malabsorption. So if there is only recurrent diarrheas, causing large quantity, frothy stools and all that, think about celiac disease. If there are recurrent pneumonias as well, or recurrent admissions for respiratory complaints and features of malabsorption, cystic fibrosis. Okay. So you have to qualify your history, especially if there is history of recurrent diarrhea and the child had gone for severe acute malnutrition. You have to think about other, maybe if there are other underlying causes. Okay. So why did you ask for history of febrile seizures?
Routine.
Nothing is routine. In this child, you ask a history, there should be some relevance. So the febrile seizures have no role. Thyroid disease.
Growth retardation, mental changes can occur if there is a hypothyroidism.
They more prone for obesity, no?
Not malnutrition.
Congenital heart disorder. Good evening, sir.
Good evening, Ma. Can you hear me?
Yeah, sir.
Good evening, sir.
Carry on, carry on. I just listen to the summary. Don't worry. Let us go on.
History of chronic cough.
To rule out tuberculosis
Fever, thrush.
and coryza, measles.
Fever, thrush and coryza will be an important history or can predispose the child with or measles. Okay. Okay, go on.
Antenatal history. Mother's age of marriage is 21 years. First pregnancy, she conceived spontaneously after 3 months of marriage. Booked and immunized at Talakulam PHC. Her AN period was uneventful. No history of any maternal anemia. Second pregnancy, booked and immunized at Talakulam PHC. Her interval was around 1.5 years. First trimester, pregnancy confirmed by urine pregnancy test. History of intake of folic acid tablet was present. No history of any fever with rash, radiation exposure, or a teratogenic drug intake. Second trimester, history of consumption of iron and folic acid tablet was present. History of tetanus toxide injection was present. No history of any gestational diabetes mellitus, pregnancy-induced hypertension, torch infections, or thyroid disorder. No history suggestive of any urinary tract infection. Third trimester.
Wait for some time.
Excuse me.
Slide.
Sir.
Yeah. Doctor, you said no history suggestive of anemia. Okay. So you mean to say mother did not have any mild or moderate or severe anemia?
Mother had anemia, sir. In her first pregnancy, she didn't have any anemia, sir.
Can you classify the anemia in the antenatal period based on anemia Mukt Bharat? Do you know what is anemia Mukt Bharat?
It's a scheme under where we give iron and folic acid tablets and biannual deworming.
What is mild and moderate and severe based on anemia book? There's a government guideline, no?
Yes, sir.
Yeah.
Less than
paramedical workers to understand, to identify the anemia. Yeah.
Less than 7 severe anemia, 7 to 9 moderate, 9 to 11 to 9 mild anemia, sir.
How many iron and folic acid tablets should the mother should have taken during the pregnancy under the anemia Mukt Bharat?
Totally 180 days during the pregnancy period and followed by 180 days after delivery.
What is the difference in the iron tablets which are being prescribed now?
Previously, it was 100 milligram elemental iron and 500 microgram of folic acid. Now it's 60. And previously, it was enteric coated tablet. Now it's sugar coated tablet.
Okay, very good. Okay, go on.
See, the anemia Mukt Bharat says when you see a mother below 7, it's meant for blood transfusion. This government guideline. When you go for 7 to 9, it meant for either iron tablets or iron sucrose. If it is more than 9, then it's more of home available vegetables and fruits and other fluids. That's what the normal guidelines. That's why people can understand even at the primary health center level when to give blood transfusion, when not to go for blood transfusion, right? Okay.
And one important history has been pointed out by PRC, sir. That is the diet during the diarrhea. That is in your breastfeeding complaints, you said there were at least 3 episodes of diarrhea. So what did the mother do for during those episodes of diarrhea? Did she continue the usual feeds? Did she give ORS or did she increase the feed or stop the feeds? All that will be an important bearing on the etiology of malnutrition of this child. So that history is a very important history as that is pointed out and should be elaborated. Okay.
Okay.
Can you elaborate what is the type of diarrhea? It is secretory or invasive or osmotic?
Secretory diarrhea, sir.
Want to vote for secretory diarrhea?
Diarrhea, sir.
Okay.
Third trimester, antenatal scans were found to be normal. Anomaly scan was not done. Total antenatal visits were 6. History of maternal anemia treated with iron sucrose injection. No history of any blood transfusion. A pre-pregnancy BMI was around 17.5 and weight gain during her pregnancy was around 10 kg. No history of any antepartum hemorrhage, postpartum hemorrhage, or premature rupture of membranes or leaking PV.
So what was the pregnancy weight gain? You would have or wished for in this child, in this mother?
More than 12 kg. Since a pre-pregnancy BMI, she was underweight. 12
So
to
what
16
BMI they
kg.
say it is underweight?
Below 19.
18.5. Below 18.5 is underweight. So the expected weight gain during pregnancy must be how much?
Around 12 to 16 kgs.
12 to 18 kgs. Okay. So what are the risk factors in this mother? What is the 100 days concept?
Initial the period where all micronutrients must be normal in mother, so that
What is those 1000 days? When do you calculate?
From the period of conception till 2 years of life.
So in the first periods of conception is very, very important. So what are the risk factors you identified in this mother?
Initially, she was underweight, and the weight gain during the pregnancy was inadequate, and there was a history of maternal anemia.
And then other one you had identified.
Anomaly scan was not done.
You said underweight, no? What was the weight of the mother?
She was 39.7 kgs.
Do you expect a 39 kg mother to gain 16 kg? Then it becomes very pathological. No? Usually the weight gain, the 10 to 12 or 12 to 14 or 14 to 16 is based on the maternal weight. Suppose the mother has got a very good BMI where the weight is more than 60, 70, then you expect 14, 15 kg rise. I feel for a 39 kg, a 10 kg is adequate. You cannot say it is inadequate. You cannot expect a pregnant lady to get 16 kg with a weight of 39 kg and going for 16 kg. Very unlikely scenario in India. So the expected weight gain during the pregnancy is based on the maternal weight. Suppose the mother has got only 39 kg, then you expect around 10 to 12 kg only. I feel this 10 to 12 kg is good enough for the mother because of her poor weight during the antenatal period, right? You can't expect 16 kg in a 39 kg mother. It's not possible.
Okay, sir.
Okay.
What is the other risk factor the mother had?
Her inter-pregnancy interval was very less, only 1.5 years.
Was it a planned delivery or
No,
planned
sir.
pregnancy?
No, ma'am.
And don't tell this history of pregnancy confirmed by urine pregnancy test. It has no relevance in any case. So just skip that history.
Okay. Natal history. Baby was born via normal vaginal delivery at Talakulam PHC. It's a full-term normal vaginal delivery. Birth weight was around 2.45 kg. The baby cried immediately after birth, and direct breastfeeding was initiated within 1 hour of delivery. No history of any prelacteal feeds or feeding difficulties during the newborn period.
Are you happy with the 2.45 kg now? I'm happy only. I'm really happy because 20 to 25% of the births is going to be below 2.5 kg. Okay. This child has just reached 2.5 kg. So we cannot say this is very poor. This 2.55, 2.45 kg is good enough. You cannot say, you can say SGA or LBW baby, but for a 39 kg mother, and she is delivering a 2.545 kg, I think I'm very happy with the weight of the baby, right? Okay.
Postnatal history, no history of any NICU admission at the postnatal period, first urine and meconium within 24 hours of life, no history of any neonatal jaundice or seizures. Developmental history, gross motor, fine motor, social and language, all the milestones, there were no developmental delay. Neck control attained at 3 months, rollover at 5 months, and now the baby sits with support at 7 months. In fine motor, now the baby has unidextrous grab. In social milestones, the baby now has stranger anxiety. Now in language milestones, the baby talks monosyllables. Diet history. Breastfeeding initiated within 1 hour of life, around 8 feeds per day, 10 to 15 minutes each feed. Night feeds were given only around 2 times. As per mother, milk secretion was poor since 3rd month of life. Hence started giving formula feed, bottle fed in improper dilution, 1 scoop per 100 ml. Ragi was in the...
How do you assess inadequacy of milk when she said that my 3rd month I did not have milk?
If the baby passes urine around 8 times per day and golden yellow stools of around 6 times per day and has good sleep in between the feeding, then the baby has adequate milk supply, sir.
No, see this old theory of passing 6 times, 8 times urine is not applicable nowadays.
Okay, sir.
Suppose you said the child was sucking only for 10 minutes. That means I take it granted that the mother is giving only 4 milk, not iron milk at all. The 4 milk contains a lot of carbohydrate. The child is going to pass 10 to 12 times urine. That doesn't mean that the mother is feeding excellently and the baby is passing urine. So that is not the criteria nowadays considered, passing urine. Even though we say for practical purpose for the paramedical staff to understand the child should pass 6 to 8 times urine, scientifically speaking, passing urine cannot be the only criteria to judge the adequacy of milk, right?
Okay,
Then
sir.
you said the child was sleeping for 2 to 3 hours. Good. That is good indicator the child is taking adequate milk. How do you test? Suppose a mother comes and asks you, doctor, please test me whether I'm having milk or not. How do you test?
We should weigh the baby pre and post.
Very good.
Feed.
That is called test weighing. That's called test weighing.
Test
Good. Yeah, right. Go on.
Dr. Tulasi, what is LAT score? Suppose you had seen the mother in the newborn period at hospital. Dr. Tulasi and Dr. Jagan. Any one of you can answer.
Latch score L will be based on the attachment of the skin, latching, whether it's sucking on the
Expand
Yeah.
latch.
latch.
L latch,
L.
A audible sucking.
A audible sucking, ma'am. T is for the type of nipple.
Type of nipple.
And B for the C for comfort, ma'am. Whether the breast
Part of the
comfort,
mother. And H for the
hold.
hold. So how do you interpret the LAT score? Do you put LAT score at your unit?
No.
So try putting the LAT score because it is a very important indicator for us to assess whether the mother needs lactation support. So if the score is less than 7, then the mother needs some amount of lactation support initially, and less than 3, intensive support is needed. So LAT score also predicts whether the mother will continue feeding like this, like after 3 months or 4 months. So ideally, we should, if we give some time to advise the mother about lactation and assess the LAT score in the newborn period, it will help us in the success of breastfeeding. How did the mother introduce ragi? Was it the ragi milk or how was ragi introduced?
She puts around 1 or 2 teaspoon of ragi, powdered ragi in water and boil it and give it to the babies. Ma'am.
She boils in water and she gives the porridge.
Yes, ma'am.
Usually they don't call that. Sometimes ragi milk is given. They'll grind it and then they'll extract the milk and give. Like 4 months, ragi is usually not started. So if you say that history, it will be just ask more history about it.
Okay. Now mother gives only formula feeds, bottle feed around 6 feeds per day. Each feed around 100 ml with 1 scoop of powder in per 100 ml, and occasionally she gives idli.
What is the age of the child now?
7 months, sir.
7 months.
Yes, sir.
Okay. I'm sorry, I'm late. That's right. Okay.
Then talk about how she cleans the bottle, whether she sterilizes, washes her hands, what water she uses for cleaning the bottle and all that. That
She
also is
says she just washes in tap water, ma'am, running tap water.
so that she doesn't sterilize the bottle.
Doctor, you said that mother has changed from breast milk to the ragi by 4th month and she felt that the milk was inadequate. Whether mother was knowing that the child is not gaining weight or the child is gaining weight, she wants to change. What happens to the weight? What the mother thought at 3rd month in the history?
Sir, mother was she took the baby to the hospital, sir, for vaccination and all. That time she was informed about the inadequate weight gain and dietary advice was given, but she didn't turn up, sir.
Okay.
This could have come in your presenting complaints itself, no? So she has given a very good history that when the child was taken for immunization, the child was not up to the expected weight. So this is a very relevant history. You should have brought it in your presenting complaints. Then all your other history will become relevant. Yeah.
Okay. Diet chart, ma'am. So the total calories required according to ICMR were 800.
Cut your diet chart. Just it's interesting. Idli and sambar.
Yes, ma'am.
You are not
Occasionally
put,
only.
you are not put value for sambar. You put only for idli.
Yes, sir.
Why? What does sambar contains?
Dal, sir. She
Definition
gives
of-
only diluted.
Definition of sambar. Can you say? It doesn't. Sambar is defined 50 ml of water where you have 2 teaspoons of dal and a handful of vegetables. That is the definition. So that means a handful of vegetables should have some calories. Dal should have some calories. So must be around 1 gram to 50 to 80 calories you should add when you had sambar. But you said only 2 teaspoons. So agreed.
That also she gives only watery.
Fine. Negligible. It's negligible. Fine. Fine. And you are very cautious to say 2 teaspoons, not 1 tablespoon. Correct. Good. So what is the protein child is getting?
Sir, according to ICMR, the required was 12 gram per deciliter, but the child gets only 7.2 gram per deciliter. So the deficit is around 4.8 gram per deciliter and 40% protein deficit. And calories, the required is 800 kilocalories and child takes about 215 kilocalories. The deficit is around 485 kilocalories and the deficit is around 60%.
So there is a calorie deficiency of 60% and protein deficiency of 40%.
40%.
So out of 12 grams, child has got 7. Then out of 485 calories, out of 800 kilocalories, child has very less calories, right?
Yes.
Okay.
And it's not per deciliter, it is per day.
Yes. Sorry.
Suppose if you have a chance to know, advice to the mother. Now you have found that the child has got deficit of calories and deficit of protein. What's your plan?
Energy, calorie dense food, like adding sugar, ghee, butter to routine food like idli.
No. How do you calculate? I'm asking you, doctor. My child has got this much deficiency. Tell me, doctor. I'm already giving this. Shall I stop it? Shall I continue it? How many food do you want to have? Whether I have money? So many issues are there. How do you do counseling to this mother?
Can continue the similar foods, but you can just enrich with some ghee or oil.
How much ghee you can enrich? Tell me. You have 1 teaspoon is 40 calories. You are deficit of around 400 calories. Are you going to add 10 teaspoons of ghee per day?
No, sir. You can add some jaggery.
Okay.
You can use.
See, your plan should be very simple. No? If the mother is giving around 5 to 6 feet, you cannot add another 5 feet, saying 10 to 11 feet. Okay.
Get some feeds with sat mixes like sat mix, some
khichdi. You are very close to Nagarkoil. That's why you say sat mixture. You don't say CPP kanji from Chennai. We have better protein and calorie compared to sat mixture. It has got 12 grams and 360 calories. Your sat mixture has only 8 grams and 320 calories. Correct?
Yes, sir.
Okay. So the idea should be like this, no? You are not supposed to disturb the mother's feed. Point number 1. Point number 2, reaching the protein and calories should be in a 1 or 2 feed. You cannot increase another 6 feeds and confusing the mother that 12 feeds should be given. Okay. So that means, as you said, you have to go for either SAT type of mixture or SAT or some CPP kanji, which gives large. That means you are 40% deficient and 60% calories. No, that means you should select a food which has got more protein and more calorie. Suppose you need only what you are talking about, jaggery oil will give only calorie, no protein at all. You are deficient with protein also. That situation, you have to select the food. That food contains more protein and more calorie. Rightly, you said it may be a SAT mixture, it may be a CPP kanji, right? Okay. Suppose you say only ghee, jaggery, that means you are increasing only the calories, not the proteins. So the selection should be in such a way that it contains more protein and more calorie. Point number 1. Point number 2, you are not supposed to have 3, 4, 5, 6 types of food, only 1 or 2, so that you can reach the deficit protein and calorie. And point number 3, it should be available in the mother and see to that it should be sustainable in the house. So the selection criteria is very important when you counsel the mother, when you want to increase the protein and calorie, right?
Okay, sir.
Okay.
Immunization history. Birth dose BCG, OPV, and Hep B were given. OPV, pentavalent, and rotavirus vaccine were given at 6 and 14 weeks, and IPV at 6 and 14 weeks. Weight gain was said to be inadequate during vaccination. Dietary advice was given, but mother didn't turn for follow-up.
Child did
So
not
where did
receive
the
pneumococcal.
mother miss the bus? Pneumococcal, Kalpana, sometimes it is available, sometimes it's not available.
Yes, sir.
Even in the government setup, it seems. Sometimes it's not available, it seems.
Okay, then you should have told the mother the child did not receive.
Whether you are, yeah.
That it must have been mentioned.
Okay.
Okay, doctor, you tell me now, where did the mother miss the bus?
During vaccination itself, the mother was advised about the inadequate weight.
Yeah, that's what I'm asking. The intrauterine growth is perfect. Yes or no?
Yes, sir.
2.45 kg, I said I'm happy. Right? But the extrauterine growth is not perfect. Correct?
Yes, sir.
So your history says very clearly, she's feeding only 10 minutes. You should give an important history whether the mother is feeding at a single breast at a time. That history is not there. That is a very important history. Will tell you that whether the child is consuming both 4 milk and 9 milk. Okay? But you are given very correctly that she is feeding for only 10 minutes and 8 times. That's what. And night time she is feeding only 2 times. That was the history you are given.
Yes, sir.
So from the beginning, the mother was missing the bus. Who is at fault?
The mother,
Don't blame the mother.
mother would have been given a proper nutritional lactational counseling initially.
The health
She
system
was
should
not.
be blamed. No, the health system should be blamed. Why the proper education and counseling was not done to the mother? I will just tell you a small example. Last week, one of the IAS officer's granddaughter from a prestigious institute, that IAS officer's daughter was feeding exactly 10 minutes and switching over to the breast every feed. The child is not gaining weight. That means feeding at a single breast at a time, that word is not given to many mothers. So naturally, here is the mother who is willing to grow the child, but unfortunately the technique is not well known in the mother side. That leads to, so you got a SAM even before 6 months. Correct? Can you accept that the child has become SAM even at 3 months?
Yes, sir.
Can you accept that the child has become SAM even at 3 months?
Yes, sir.
Yes.
Yes, sir.
What is the criteria to diagnose SAM before 6 months?
If there is a visible severe wasting and
Yes.
there is bilateral pitting pedal edema and
Yes.
the mid upper arm circumference less
Oh,
than
why 3 months?
uh,
3 months.
sorry,
3 months.
if the length is less than 45 centimeter,
55.
No.
sorry, 66 centimeter.
No. See that see, you can claim SAM before 6 months only when the child crosses 49 centimeter length. Why WHO is very specific about it? Can you? Why the WHO wants the child to cross 49 centimeter to classify under SAM? What are the two IUGR you know?
Symmetrical and asymmetrical.
What will happen to the symmetrical IUGR? What will happen to the asymmetrical IUGR? Pathology.
During the initial period, if there is some like first 3 months, if there is some uteroplacental
Very simple, ma.
in during the late
hypertrophy of the cell is affected in asymmetrical
asymmetrical
IUGR.
Hyperplasia in
Is affected in symmetrical
symmetrical
IUGR. That
IUGR.
means symmetrical IUGR will not reach 50 centimeter at the time of birth. Right? That's why WHO says, if you want to consider nutritional cause for SAM, you may consider genetic cause, chromosomal cause for SAM. But to consider nutritional cause for SAM, the child should reach a height of length of 49 centimeter. Okay. So this child, from your history, the child has become SAM even at 3 months because of the wasting, because of not gaining weight. Maybe we have not seen the weight for height for this child before 6 months, but these are the reasons. Any other reasons you can give, child can become SAM even before 6 months. Other 3 reasons apart from this. Any other reasons you can see SAM even before 6 months? By low birth weight babies and preterm babies. you expect they may go for SAM before 6 months. Recurrent infections and diarrhea in the first 6 months can lead to SAM. Any congenital malformations, baby with heart disease, with intestinal problems, they can go for SAM. There are 4 etiology was shown where the chances of child becoming SAM before 6 months, right? Why do you want to diagnose SAM before 6 months? Why can't you diagnose after 6 months?
Initial period is more
There
initial.
are other PGs can answer also. Because the mortality in SAM before 6 months is much higher compared to the mortality after 6 months. So the time has come that you should start diagnosing SAM even before 6 months. You can write SAM even for a 3-month baby, but we used to write only failure to try. You can replace the word with SAM hereafter if the length is more than 49 centimeters. Okay, right.
What advice should have given if they seen the child at 3 months and the child was not gaining weight? That was what sir was trying to say. You have ruled out organic causes like congenital heart disease, renal tubular acidosis, and all that. If it was only nutritional, what advice would have given?
Lactational counseling regarding adequate breastfeeding.
Sir has already told you. Be specific about lactation counseling.
To adequately breastfeed single breast at a time and have
emptying the breast. Mother should empty the breast before going on to the next breast. Then
night feeds.
Okay, very good. Night feeds. Then how should the mother feed? When should the mother feed?
Ma'am?
When should the mother feed?
Responsive feeding should be practiced, identifying the early cues and feeding the baby.
What are the early cues?
The mother, baby will open the mouth, turn the head towards the mother.
Towards the breast, and then you're lost at that point the mother has not given. What are the other things the child will start doing?
Will just turn up to the breast, open the mouth.
Open the mouth சொல்லிட்டீங்க அதுக்கப்புறம்
stirring.
It will become more alert and active. Becomes more alert and active, and then it will bring the hand to the mouth.
Child will produce a lot of sounds. Child will show a lot of sounds like chop, 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 something like that. They will show to the mother, I need.
Start sucking. When they're just making sounds with it. Get the word.
Okay.
So these are the mothers to start feeding on early cues or responsive feeding. Suppose the child was not accepting. What other method you can use to initiate or give time for the child to start feeding? Any method you can make the child adjust to the breast. The mother has already started on formulas.
Supplementary suckling method.
Should start the child on supplemental sucking. Suppose you're not, there is failure, there is no feeding. Supplemental sucking was not possible in the child. What are the other things that the WHO advocates? The child had already gone for SAM. In a child less than 6 months.
Diluted F100.
Okay, they can give F75 itself or infant formulas also. Of course, again, the FAS criteria has to be satisfied, but try your best to establish feeding, breastfeeding. But these are the other options that you also have. Go on.
Family history, non-consanguineous marriage, nuclear family, no broken family or family disputes, no history of any chronic infection, disease, or sudden death in family members.
What is the importance of broken family and family disputes?
Psychosocial impact. The mother will have an impact which will decrease her breastfeed and which will decrease her affection towards the baby, which may have an impact on the baby's nutrition.
No, affection will not go down. Your prolactin and oxytocin will go up. Affection will be there for any mother to any baby, whether they hit by the husband or not. That will not go. But the prolactin and oxytocin suffers. So the milk secretion goes down. The ejection goes down. Okay. That's why now we are changing the words. Previously, we used to say willing mother, sucking baby. Now the mother is willing, but milk is not coming. So the scenario now we are changing, not willing mother, happy mother, sucking baby. We will change. When the mother is happy, the secretion is going to be more. I think India is missing. 45% of the mothers are not happy, either with the husband or with the family. That's why they are not able to initiate the breastfeed. 55% our initiation of breastfeeding. 60% is our exclusive breastfeeding. That means 40% mothers are not happy. They may say a lot of reason, inadequate milk and other things. Okay. Why this mother would have felt unhappy? You said no broken family, no family dispute, husband is taking care of the wife. What made her to think that she did not have milk?
False perception.
That's
Maybe.
what made her? What false perception? What is the history there?
She said baby was still crying in spite of.
No. What the mother would have thought, I will not have milk. Her weight, no. Many mothers feel, I'm only 39 kg. I'm not 50 kg or 60 kg. So I cannot produce milk. That is a false thing mother always thinks, no? The weight of the mother. She always feels, yeah, I'm less weight. That is enough, no? Okay, go on.
Socioeconomic history. Lives in Pakka house, 2 rooms, bathroom facility available. Use unboiled tap
Pedigree?
water.
Nothing to say in the pedigree.
No, sir. 2
Okay,
years.
saw the
First
pedigree.
child is 2
How
years
about the
now.
first child?
The interpregnancy interval, the interval between the 2 siblings is very less. Sir.
Okay, so
How is the first child?
First child is underweight, sir.
That means the mother is not learning even from the beginning. No. First child is underweight. Okay.
Socioeconomic history. Lives in Pakka house, 2 rooms, bathroom facility available. Use unboiled tap water for drinking. No open air defecation. Father studied till 10th standard. Mason by occupation. Mother studied till 10th standard. She is housewife. Monthly income is around 10,000. According to modified Kuppasamy scale, comes under lower socioeconomic class. Summary: the 7-month-old male baby, second born of non-consanguineous marriage, belonging to lower socioeconomic class, with maternal anemia at pregnancy, exclusively breastfed for only 3 months, bottle fed with improper formula feed dilution, with improper complementary feeding practices, with the calorie protein deficit diet, immunized for age with no developmental delay, with history of loose stools, fever and reduced urine output, with past history of 2 episodes of acute diarrheal disease. The probable diagnosis is acute watery diarrhea with some dehydration and undernutrition.
Again, you have not reading the history of Sam here.
Why you want to say undernutrition?
Mm,
What is the weight of the child now?
5.3 kg, sir.
Huh?
5.3 kg.
5.3 kg. Okay. Still, your since it's a history, you want to say like that. Maybe
Yes,
after
sir.
the growth
After the
plotting, it may change.
anthropometry.
Fine.
General examination, child was irritable, not interested in surrounding, febrile, pallor was present, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy, no pedal edema, tongue was dry, eyes were sunken, urine output was decreased.
Classify the
Temperature,
pallor. Go back to your previous slide.
mild pallor was present.
Would you use the term mild pallor during examination? How do you classify pallor? Where do you look for pallor?
Conjunctiva, arms,
In this child,
For conjunctiva,
in this child,
7-month-old.
palms.
Or palmar pallor. With palmar pallor, how do you classify the pallor?
No pallor, some pallor, severe pallor.
Very good.
okay.
Can Jagan talk more? No, some and severe pallor. Okay. There is no pedal edema.
No, ma'am.
How do you look for pedal edema?
In dorsum of foot, we have to press.
How do you hold the foot?
With both hands, thumb above and 4 fingers below, ma'am.
And then what you do? You hold the foot and then you press for how long?
Around 2 seconds.
2 seconds. 2 seconds is just like this.
5.
Suppose you have pedal edema, what will be your diagnosis?
Caution.
No pedal edema. Suppose if there is pedal edema, what will be the diagnosis?
Kwashiorkor.
You want to say kwashiorkor. Why some children are becoming kwashiorkor? Why many children are becoming marasmus?
Depending on if there is adaptation, they'll become marasmic children, sir. If the adaptation has failed, Due to disadaptation, they'll become kwashiorkor, sir.
That is the old theory. What I'm asking, why kwashiorkor is having fatty liver with hypoalbuminemia? Why marasmus is not having fatty liver?
Sir, due to
Amino acid pool.
In
amino acid,
kwashiorkor, there is decreased cortisol, sir.
Okay.
So there is decreased amino acid level and decreased lipoproteins.
lipoprotein lipase.
So there is a fatty liver.
That is not the reason now. The reason says there is a deficiency of insulin and insulin growth factor, which takes place in the protein degradation, which takes place in the fatty acid oxidation, which takes place in the peripheral utilization of glucose when there is a glycogenolysis. Whenever the baby is under stress, when the baby is in catabolism, you know there is a glycogenolysis, protein degradation, and fatty acid oxidation. All these three things has been taken care of by the insulin and insulin growth factor. We have seen in some of the kwashiorkor children where the insulin and insulin growth factors are very low or absent. In that situation, the fatty acid oxidation of extra fat is not getting utilized by the brain and getting deposited in the liver, produces fatty liver. The peripheral utilization of glucose is not happening, so kwashiorkor may not be going hypoglycemia unless and otherwise there is associated fulminant sepsis. And there is a decreased conversion of protein by the liver that leads to hypoalbuminemia, that leads to edema. So here is the peculiar scenario where the etiology is starvation and not eating, but you get a two spectrum of disease, one child with thinness, another child with the edematous. So the reason is that. So you can easily do some study and see how many kwashiorkors are having insulin and insulin growth factor. Then you can easily find out that could be the reason they are going for edema, fatty liver, hypoalbuminemia, and all those things, right? Okay.
You look for edema somewhere else.
Any sacral edema, periorbital puffiness,
Okay.
Periorbital puffiness. What
vitals,
in the state? Go on.
vitals, temperature 100 Fahrenheit at axilla, heart rate 120 per minute, regular rhythm, normal volume, no specific character, all peripheral pulses force, no radiofemoral delay, respiratory rate 42 per minute, workup breathing normal, capillary refilling time is less than 2 seconds, BP 90-60 millimeter of mercury, saturation is 98% at room air. Anthropometry, weight for age observed is 5.3 kg against the expected of 8 kg, 62%, which comes under -3 standard deviation, and baby severe underweight. Length for age is 66 centimeter against the expected of 69 centimeter, which is 95%, which comes in 0 to -2 standard deviation, which is normal. Weight for length is 5.3 against the expected of 7.5 kg, which is 71%, which is less than -3 standard deviation, and there is severe wasting. Head circumference for age is 42 centimeter, which comes in 0 to -2 standard deviation, which is normal, and the mid-upper arm circumference is 11 centimeter, which is less than -3 standard deviation. It comes in severe acute malnutrition.
You want to examine mid-upper arm circumference for a 7-month-old child also?
It's 6 months to 5 weeks. Yes, sir.
What is the normogram? What do the before 6 months? What will be the mid-upper arm circumference for a normal child with normal weight? Do you have any data for that?
It's
Still lot of studies are going on. Still, the government guidelines, WHO guidelines take MUSA after 1 year only. Okay. So government always says above 1 year, when it is less than 11.5, you say SAM. So 7-month child, 11 centimeter, you may say SAM as per your mid-upper arm circumference, this one or a Shakir tape. But if you put the Shakir tape in the 7-month-old child, then you may be saying something different. So it is always not to comment more about mid-upper arm circumference for a 6 to 7-month-old child. 1-year-old child, you can do that also. Okay? Right.
Weight for age, which comes below -3 standard deviation, length for age between 0 to -2 standard deviation, and weight for length comes in less than -3 standard deviation. Head circumference for age between 0 to -2 standard deviation, and mid-upper arm circumference below -3 standard deviation.
This is acute malnutrition or chronic malnutrition?
Sir?
This is acute malnutrition or chronic malnutrition?
Acute on, it's acute malnutrition, sir.
Why you want to say something acute on,
No,
but
sir.
dragging something?
No, sir.
Unless
The
there is stunting, you are not
stunting,
going to talk about chronic.
chronic.
What is Levin's classification?
Lemons,
Do you know what is Levin's classification?
No,
Chronic mal. There is a classification for chronic malnutrition also. Do you know?
No, sir.
Suppose the weight for age is -3, height for age is -3, weight for height also is -3. It is chronic malnutrition of acute onset. Suppose weight for age is -3, height for age is -3, weight for height is normal. It has become normal. That means it becomes a chronic malnutrition of chronic nature, very difficult to repair also. So when you see stunting, the pediatrician's role is to find out whether this chronic malnutrition can be easily treatable or not. Suppose you have a weight for height is normal, then you are in trouble. So all are -3, I can treat recent onset. Weight for height has become normal. It is like seeing a achondroplasia, where the height, the weight is going to be normal for the child. A 3 feet height child, he may be around 15-20 kg, it looks normal. The weight for height looks normal, right? So that's why the Levin's classification always tells you to use in chronic malnutrition whether I am going to have a good prognosis or bad prognosis with my nutrition advice, right? Okay.
Doctor, from your anthropometry, can we say failure to thrive for this child?
Weight for age is less than -3 standard deviation, ma'am. But
What is the definition for failure to thrive?
weight for age should be less than 3rd centile, and there should be down crossing over 2 major centiles over a period on 2 occasions.
Weight for age should be less than 3rd centile over a period of time. So with one weight recording or one height recording, we cannot say whether this child has failure to thrive or not. So your answer is no. So from this, we can say whether it is acute or chronic or acute or chronic malnutrition. Okay, go on.
Head to foot examination, head shape normal, no frontal bossing or hernia tape, AF open, hair thin, lusterless.
AF, comment on the AF. Child has diarrhea.
I can see a scaphocephaly. You say it is normal from the photo.
Shape of the head.
It looks like scaphocephaly, no? Right.
Comment on the AF, doctor.
AF was open around 1.5 to into 1.5 centimeter, was sunken, hair thin, lusterless, brittle,
Or
not
sunken.
easily.
So if it is sunken, what do you interpret it? How do you interpret it?
Due to dehydration.
Otherwise, it is always dehydrated.
Normal children will have a normal sunken this one, no?
Even in mal.
How do you examine the AF? Tell me.
In sitting
where
position.
do you put your hand? From where you go?
From
how do you clinically examine AF?
From and we have to place the from the.
It should be always from the side. From the beginning. Don't put your finger on that. Okay. Even in newborn, if you want to feel, from the side, you should move your fingers. Okay. Generally, you will have a small depression. No.
So if it is depressed, it can be normal also.
Okay, it may be normal. No, you want to give importance to the sunken AF in this child. Now, don't have diarrhea now.
No, child presented with diarrhea. The present complaint was diarrhea and fever.
That is long back. No, during the examination, it was not there.
When did you examine? What was the course in the hospital? When did you examine the child?
During admission, ma'am.
So day 1 of admission.
At that time, the child had diarrhea.
Yes, sir.
Okay,
admitted with diarrhea.
Okay, right.
So in that case, you give importance, but in a marasmic child, the AF can be normally sunken also. Doesn't actually indicate dehydration. Okay.
Hair thin, lusterless, brittle,
not frontal bossing or no?
These are the children. You should give importance to the flushed with surface or bulging AF. Because of the immunosuppression, many SAM children may not exhibit the meningitis symptoms and signs. Sometimes very difficult to examine these children also. So any SAM children, instead of going for, I have got so many ways to look for dehydrations. looking at the eye, looking at the mouth, skin pinch, tongue dryness, thirsty or refusal of feed. So many signs for dehydrations are there. I would give an importance to the area of when it's flushed with surface or bulging with surface, right? This sunken may not be able to give much importance to this type, right?
And in the hair, we usually, although we know it is easily pluckable, we don't give that history. We don't examine, we don't pluck at the hair and say whether it is easily or not easily plucked. So that history is usually in that examination findings is usually skipped.
Well, she has written not easily plucked. That means you have tried.
You have tried.
No.
Then why do you write not easily pluckable?
Shouldn't be there. Why no alopecia? Suppose there was alopecia, what have you
In
done?
biotin deficiency, there will be areas of alopecia.
Why you want to talk a lot of those things, ma? Straight away go and talk. Hair is fine. That's all.
Okay, sir.
Don't get into trouble by saying.
Okay,
Right.
sir. Face no dysmorphic features, eyes sunken, pallor present, no icterus, no signs of vitamin A deficiency, ears normal, no
What
discharge,
species
mouth.
you will see in exam?
Ma'am,
Suppose a child was a kwashiorkor, what species you would have seen?
moon facies.
Marasmus is
I want the excellent English word. Tell me, what is that?
Old man appearance in marasmus
No.
moon faces in
Moon face is right, ma. Can you describe the behavior of the child? Excellent, beautiful English word.
it'll be apat
Sugar baby.
Good. Add
Yes.
one more.
Sugar baby.
sugar baby.
Sugar baby, lama. Mental apathy.
Mental
Yes.
apathy.
Yes, that is a very typical pathognomonic for kwashiorkor. No, right.
You can comment on the social smile during examination also, whether the child interacts with the mother and whether the child has a social smile when you are examining. That will also be an important examination finding.
Mouth, no oral thrush ulcer, no pharyngitis or tonsillitis, no ankylostomatitis.
Why did you
Tongue
look for
dry.
pharyngitis and tonsillitis in a 7-month-old? The child have pharyngitis and tonsillitis? Not, it's not relevant. We usually are bothered about it in a child more than 3 years of age or even at least more than 5 years of age.
Then in
Never
the
in a
exam, a lot
7-year-old.
of ENT questions will come. Then you become a ENT PG, not the pediatric PG, right?
Tongue
Right.
dry, no glossitis, no chest wall deformity, no Harrison sulcus or actinic rosary, nails pallor present, no deformities, no spooning of nails, no clubbing, skin, no
How was
flaky
your,
paint or
see, from head to foot examination, you could have removed the shirt. No, did you remove the shirt and examine the child? You're
yes,
given a
ma'am.
photo with the shirt on.
Yes, ma'am.
What will you look for in the chest? Other than chest wall deformity, how will you describe this child? With the shirt on, you're not able to get, have an idea how the child looked actually. What and all you look for in the head to foot?
Head, any craniotapes, frontal bossing.
In the chest, suppose the child was not wearing the shirt, what do you look for? Or what do you describe? The chest. You said rachitic rosary, no Harrison sulcus, then?
Barbotic rose.
Talk about the ribs, whether the ribs were easily visible, both anteriorly as well as posteriorly, whether it's any pectus carinatum or excavatum that was noted. The ribs, all that can be seen only if you remove the chest and give us a picture. Okay. Then, how was the wasting? Was there wasting or not? How was the buttocks? Did you examine the buttocks of the child, the thighs of the child?
No significant wasting noted in buttocks. No.
Buttocks or thighs, you didn't notice any. So that should be coming in your.
Significant wasting.
That should come. Visible wasting should be commented upon. You say visible severe wasting, no. That should come upon in that history or that examination finding should be talked about. Okay.
When do you get all these clinical signs?
Sir?
When do you get all these clinical signs? Widening of wasting completely. Gluteal region, you can see a baggy pant appearance. There is a flaky pant dermatosis. There is plucking of hair, flack signs. When you get all these clinical signs in a SAM child?
Marasmic.
When they're really going towards chronicity. What you are dealing now is an acute problem. So during the acute problem, we may not be visualizing. For example, I'll tell you, the cerebral palsy was seeing on the third year with the rackety rosary, with the vitamin D deficiency, wrist widening. The child has gone for chronicity. I told you already, when there is a stunting started taking place, that means the child. So most of the clinical signs will be visible when the child reaches chronicity. During the acute period, these signs may not be much visible, right? Okay.
Yeah, but you should look for them. Only then you will know whether it's present or not. Anything other than the skin?
No, ma'am.
What do you look for other than these things? Flaky paint or crazy
Painter.
paint? The child had dehydration,
Skin
diarrhea.
tug.
What was the skin
Tug
color in this child?
was increased, ma'am.
It was prolonged.
Pro-
It
Yes.
was prolonged is an important finding, no? In a child with ongoing diarrhea. Of course, it might be prolonged normally also in a child with marasmus, but comment on the skin turgor also. Suppose a child had petechiae or purpura, what would you think of?
Vitamin K deficient, vitamin C.
Child was very
Vitamin
sick, lethargic, treated for septic shock, what will you think of with petechiae and purpura?
Coagulation
Sepsis also given the answer. Gram-negative septicemia and DIVC. So if there is petechiae, don't always think about vitamin deficiencies. In Assam, they're very prone for bacterial infections, especially gram-negative septicemia. If there is petechiae or purpura, think about sepsis and DIVC. Okay.
When do you suspect sepsis in this child? Without doing blood investigations. What WHO says? What WHO says when we should consider sepsis, even though the clinical signs are not there.
Baby is very much lethargic, irritable, and not able to take any feeds.
These are all clinical signs. When there is an hypoglycemia associated with hypothermia, that's why the WHO says the child has hypothermia, or the child has hypoglycemia, or the child has both. You don't search for sepsis. Start ampicillin 50 mg per kg 8th hourly, gentamicin 7.5 mg OD, irrespective of the status of the child. That's a WHO guideline. So whenever a child is having an episode of hypoglycemia or an episode of hypothermia, you should suspect sepsis and start treating sepsis with ampigenta, broad spectrum antibiotic. Then, of course, then you search for other investigations and do, right? You cannot wait. The child will have pneumonia. The child can have UTI, something like that. Any episode of hypoglycemia or any episode of hypothermia, suspect sepsis in a SAM child, right? Okay.
Will you expect signs of rickets in this child?
No, it usually occurs in growing bones.
So it is an old school teaching, but now studies have shown that they can have features of rickets, but generally they say that it is a growing bone, so features of rickets are usually not seen. Okay, go on.
No perianal excoriation, no
So if
external.
you see perianal excoriation, what and all you think of
Due
in
to
this child?
osmotic diarrhea.
Osmotic diarrhea.
Perianal excoriation can occur.
Zinc
What is the
deficient.
zinc deficiency? In a child with SAM, think about perianal or periorificil excoriations, think about zinc deficiencies. Then what else?
Lactose intolerance.
Lactose intolerance. Huh?
Celiac disease.
Finally, it could be just moniliasis also. They are prone for candidiasis, candidal infection. So think about these three when you have perianal excoriation. Parotid enlargement.
In nutritional recovery syndrome
HIV.
and HIV.
So it is one of the screening tools for HIV infection. And sometimes parotids can be enlarged also.
Somebody said nutritional recovery syndrome. What are the biochemical changes you see in nutritional recovery syndrome?
Hyperglycemia,
Hypophosphatemia.
hypophosphatemia, hypomagnesemia, hypernatremia,
Hypernatremia.
You missed the most important one.
Hypokalemia.
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 Okay, right. Go on.
Examination of abdomen, inspection, shape normal, no distension, umbilicus midline, all quadrants move equally with respiration, no dilated veins, cast sinuses, no visible peristalsis, genitalia normal, hernial orifices were free. Palpation, abdomen soft, no tenderness, no godding or rigidity, no organomegaly, no mass palpable. Percussion, liver span was around 5.5 centimeter, no free fluid. Auscultation, normal bowel sounds heard.
Are you happy with the liver span of 5.5 for a 7-month-old child? Are you right or still more?
Around 6 centimeter usually.
You want to say that liver is shrunken.
It was
So be
5.5.
careful when the liver pathology is not there. Be careful when you are telling the examiners the right liver span. Usually the 5 to 5.5 say, I say even in newborn. So you cannot say the liver is 5.5 centimeter in a 7 and 8-month-old child. No, it should have crossed 6 or something. So otherwise they say liver span normal. Don't put 5.5 centimeter or 6. Let the examiner ask you, what are the newborn liver span? What is 1 year liver span? What is 5-year liver span? Make the examiners to ask them questions so that you can answer many questions. Okay. And saying the 7-month-old child with liver span of 5.5, I may take it that there is a shrunken liver is there. Okay. So let's put liver span. You say it's normal, no?
Around 6 centimeter.
No. Your impression is normal.
Normal. No.
Let's put it as normal, right?
Okay. Other system examination, respiratory system, normal vesicular breath sounds heard, no added sound. Cardiovascular system, S1, S2 present, no murmurs. Central nervous system, no focal.
You want to examine the apical impulse in this child?
Yes, sir.
What for?
Any congenital heart disease.
No,
We
congenital heart
expect
disease.
the heart size in this child.
Cardiomegaly can microcardia you should or
Very
cardiomegaly.
good. Yeah. Sometimes because of the anemia, you may have a cardiomegaly, but generally some children can have microcardia.
Microcardials.
Cardia, right? That's why I'm asked. Good.
Why
Right.
did they go for cardiomegaly?
Ma'am?
Why did they go for cardiomegaly? Why did they go for microcardia?
Cardiomegaly can occur due to anemia with CCF, or it can also occur in selenium deficiency, or it can also occur with vitamin D with cardiomyopathy.
Which vitamin B?
Vitamin B1.
Vitamin B1. Vitamin B1.
So thiamine deficiency can be because of iron deficiency. Or what are the other causes? Suppose a child who had edema, what the other cause? Could just be fluid and water retention in a kwashiorkor child. That can also cause a cardiomegaly. So you have to examine where is the apical impulse in this child. Okay. The respiratory system examination, is it important or not?
Important.
So why it is important a child with SAM?
Any pneumonia.
What is different in the pneumonia in child with SAM? More than pneumonia?
Recurrent pneumonias.
Not recurrent pneumonias. So sodium retention, inoperable IV fluids. That could be fluid and water overload also causing cardiomegaly. You should always think of tuberculosis. So examine the respiratory system for any added sounds, any decrease in sounds on one side or all that. So it can be tuberculosis, and pneumonia can be silent in this child. They can have lung infection without increasing respiratory rate, or even without an increasing, without increasing their respiratory distress if they're very decompensated. So respiratory system examination, you should examine for silent pneumonia as well as for tuberculosis. CNS examination.
Dr. Jagan.
Sir.
Suppose the child has got a respiratory system problem. You are suspecting tuberculosis. MAN2 is negative. CBNAT is negative. RGJ is negative. There's history of contact with tuberculosis. What is your decision?
Chest check straight.
Normal. What the WHO says? WHO says that if all these investigations are negative, you have to go for empirical ATT if there is a strong history of contact with tuberculosis. Because of the T-cell immunosuppression which is taking place in SAM children, many of the investigations may not help you to make a diagnosis. So the guideline is from WHO. The SAM children with clinical symptoms looks like a tuberculosis, but the investigations are not supporting. and there is a strong history of contact with tuberculosis, you have to go for empirical ATT, right?
Okay.
In the CNS, do you expect focal neurological deficit or anything else? I definitely won't look for focal neurological deficit.
What will you have a CNS in the Samson?
There will be apathy. The child will
CNS,
be
tone.
Hypotonia.
hypotonia.
Yeah, that should be your examination. How was the tone? What will happen to the reflexes? The reflexes can be
Those will
depressed. So don't say this for no focal neurologic deficit in any case. In this case, what I'm expecting, that only you should examine and that should present. Okay. Okay.
Diagnosis: a case of severe acute malnutrition, grade 2 according to IAP classification, severely underweight and wasted, with acute diarrheal disease with some dehydration, with micronutrient deficiencies, anemia, etiology being nutritional due to faulty feeding practices, due to biological, environment, and psychosocial factors.
What psychosocial factors you identified?
My mother was social factor. Mother was having no proper awareness of the lactation method, and she was not practicing proper hygiene while preparation of
What do you mean by grade 2 according to IAP?
Depending on the percentages, it's
that is outdated
66.
no, from 2005. These are all called age dependent criteria. Now we have come to age independent criteria.
Wait for it.
IAP classification, Gomez classification, Wellcome classification, they did not take height into consideration at all. All this classification based on weight only. Then the WHO thought they should include the height also. So you say, according to you, grade 2, according to IAP classification, you mean to say that it's 60 to 70%, right?
Yes, sir.
So it is now not like that. Okay. So in the examination, you'll be always talking about whether you are talking about SAM or MAM. Okay. Some examiners ask you, can you describe in IAP form? Then you can describe. Because IAP classification based on the percentage of weight doesn't take height into criteria. All this has got changed after 2005 because no, Iranian ladies are very tall, Singapore and Korean ladies are short, Indian ladies are average. There is a lot of differences in the height between each and every segment and geographical area. So that's why WHO has come into the criteria, not going for the age-dependent criteria. This is going called age-independent criteria, whether it's a 3-year or 2-year or 4-year. See the weight for the height, and based on that, the classification comes as weight for height less than -3 standard deviation. Okay, these are the things when the examiner asks you, you can tell. And don't go put it and get into trouble, right? Okay.
What are the other age-independent criteria? Sir has already told you weight for height. Anything else?
You have described one.
Bit upper.
Yeah, very good.
Bit
Bit upper arm
circumference.
Then young child, newborn, what else? Or an older, what else?
Have you used Erpenden's calipers?
No, sir.
Have you seen Erpenden's calipers? Have you seen Erpenden's calipers?
Picture we have seen, sir.
Tell your HOD Dr. Suresh to buy through Amazon. It costs around 200-300 rupees. Have it in the oral examination or the IVA. What is Erpenden's calipers? You can see also. No, we are not practicing, but some examiners may ask you whether you have seen that. Did you see our Shakir tape?
Yes, sir.
You have Shakir tape?
Yes,
Have
sir.
Shakir tape.
Where did you buy?
We have in the department.
It is available only in the Amazon. It's not available in any market. Only through Amazon you can get it. No, I'm not promoting Amazon, but I am promoting you to see Shakir tape and Erpenden's calipers, right? Even though we are not using, but you should see. Okay.
Other things are BMI and Ponderal index. So we are now going on to age-independent criteria for diagnosis of SAM. So BMI is more important, Ponderal index, mid-upper arm circumference, and most important, weight for height. Okay.
And Nagalakshmi also can, we both of us are blocking Nagalakshmi, I seems. Nagalakshmi, you can come in the screen and ask questions. Your own postgraduate. Hope we are not blocking you. Nagalakshmi is not there.
I didn't see
Okay.
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 Okay, go on.
Go.
Again,
Investigate-
biological, you say biosocial, psychosocial. What biological thing you identify?
Now the child is having diarrhea already. Two
That is an
episodes.
acute episode. For the SAM, if you say biological, some other biological etiology you should have identified.
Okay.
Environmental, psychosocial, everything
social.
should be, you should justify your diagnosis from your history. But history is not,
Environment, they belong to lower socioeconomic class.
that is
But,
social. That is not
Ma, after
environmental.
post-COVID, everybody has become like that, ma.
Okay, go on. Go to your next slide.
Yeah.
Lab investigations, complete blood count in I
Don't
look
say
for
complete blood
anemia.
count. Complete blood
I'll-
count is something we don't say in any presentation.
I
What do
look
you want
for
to say?
HB, I look for anemia. For infection, I'll look for total count, differential count. And to rule out hypoglycemia, I look for blood sugars. To rule out any dysalktolemia, I look for serum electrolyte, sodium, potassium. To
What do you
rule out
expect the sodium and potassium to be?
usually there'll be hypernatremia and hypokalemia.
How will the sodium be?
Hypernatremia, increase sodium and decrease potassium.
Why
That
do
is
you
total body sodium.
why you are not using
Total
ORS?
body sodium will be decreased, but due to shifting of sodium.
You need not see hypernatremia in all cases. It is the total body sodium that shifts. Sodium goes inside the cell. But you don't see hypernatremia in children with SAM. But you will see hypokalemia because potassium is lost in the urine. Why sodium and potassium is altered?
No, the take-home message is hypokalemia, even if there is hyponatremia, you need not treat because your sodium is sitting inside the cell. Okay. If you start correcting the potassium, the sodium will come all right. That's the take-home message. You may not go for hypernatremia. That's why we are using Resomol rather than ORS. ORS contain 90. I want 45. That's why we are going for Resomol. If I don't find Resomol, put ORS in 2 liters of water, add potassium, and start using. So this is what we call reactive adaptation. The sodium is going into the cell and potassium being lost. You may have blood samples of hyponatremia and hypokalemia also, but I will not be eager to treat hyponatremia. Suppose the sodium goes 120, then I'll be eager to treat. Okay. As long as the sodium goes around 125, 126, you can wait and watch. You need not treat the sodium at all. That is the take-home message. There's no question of going for hypernatremia unless and otherwise there is transepidermal loss of water is more. You may not be seeing it is usually seen in newborn, not in many conditions, right? Okay.
Look for serum protein, serum calcium, and magnesium.
What do you expect the serum protein to be in this child?
Decreased, ma'am.
Is it always decreased?
Do you want to say all children have low sodium?
It may be decreased. It may be decreased.
That's what I told you, no, that insulin and insulin growth factors.
Depending on the.
Yes. So not necessary that all should have a low albumin. Okay.
The proteins can be normal unless the child has kwashiorkor. If the proteins were decreased, I would also think whether the child was in pre-kwashiorkor stage, not yet developing the proteins, edema or something. Even sir has pointed out that the look of the child looks like a pre-kwashiorkor, little bit of edema like that. Okay. A puffy child, not actually edema, a puffy child. Okay.
What do you want to take chest X-ray? No? What are the things you want to see in chest X-ray?
Sir, any patches to rule out pneumonia, and there is any bony changes to rule out any rickets.
Any other?
In the examination,
any cardiomegaly or cardiac changes, cardiac shadows.
Any other? What do you see in the cardiac pedicle?
Any lymph node?
You see anything? See that will show the time. Usually cardiac pedicle, you see the thymus, no?
Thymic shadow.
Yeah, sometimes in SAM, when they have got severe immunosuppression, sometimes
The
thymus
thymic atrophy.
narrowing of the cardiac pedicle. Generally, we say narrowing of the cardiac pedicle more in favor of sepsis. Radiological feature for sepsis is narrowing of cardiac pedicle, hyperventilation, tenting of diaphragm, and dilated lobes. Sometimes in SAM child, when there is severely immunosuppressed, you may not be the thymic, the cardiac pedicle will be very narrow also sometimes, right? Okay.
Don't stop a chest X-ray alone. Do a manto and always look for resting
You
acid
have not
juice.
mentioned Mantu in this child, not necessary. That too, Kalpana is sitting there. You don't
In
want
all
to do.
cases of SAM, how we have to rule out tuberculosis. So, can we do manto on this child?
Manto, due to immunosuppression, even if you do, sometimes
Will
you'll
you
get
give
a
manto or not?
No,
That is your
not like that.
interpretation.
Not like that. Sometimes many textbooks says in a immunosuppressed child, in a HIV child, in a SAM child, 5 mm Mantu is significant. Significant. 5 mm is very significant, right?
Okay.
Okay. You should put Mantu, definitely. You are not supposed to miss.
Okay, go on.
Urine routine, urine culture, and blood culture.
Okay.
Mm.
Thank you. Okay, what is your plan now? You have done an investigation for this child. This is a 7-month-old child. Now you are talking to the mother. What is the type of food you are going to address to the mother? How you are going to counsel the mother in this child?
Initially, I'll start with the F75 diet during the initial stabilization phase. Then,
See, this child, how will you manage? What was the diagnosis? How will you manage this child?
initially we'll be treating hypothermia. We'll put in a warm environment with double clothing.
Child had febrile, no? Child was febrile. 100 degrees was your temperature. Always say, how will you treat this child?
Okay, ma'am. The child didn't had any symptomatic hypoglycemia, so I'll just. But the child was having some dehydration, so I'll give some dehydration correction with 5 to 10 ml per kg per hour of Risomol. I'll slowly correct over a period of 12 hours. Then I'll start.
How do you prepare Risomol?
We'll dissolve WHO low osmolality ORS in 2 liters of water and add 50 gram of sugar and 40 ml of mineral mix solution or 45 ml of syrup KCl.
What is there in what minerals are there in Risomol, which is not present in ORS?
Citrate, magnesium, copper, zinc.
Okay. Magnesium, zinc, and copper. Okay. Okay. So first you will be correcting. You will correct for the hypoglycemia. You check for the hypoglycemia.
Then I'll correct the dehydration. Then I'll start cautious feeding with the F75.
When you know the child is responding to your hydration, when will you stop your hydration, or when will you know the child is improving?
Urine output
should increase.
Should increase, and there will be heart rate. I'll assess heart rate, respiratory rate.
But should be fall or rise?
Heart rate, there'll be
heart rate.
Heart rate change of around 15 per minute and respiratory rate of 5 per minute.
Change na and increase or decrease?
Heart rate will decrease, ma'am.
Respiratory rate will
decrease.
Say if it was previously increased, there was some tachycardia, some 120, 130 or 140, a decrease in the heart rate by 15 and respiratory rate by 5 is one indicator that your child is improving. The urine output will be better. Then
appetite will
child will be eager to drink, or if the child was initially eager to drink, the thirst will be better. Then the skin turgor will go back less slowly. The eyes will become normal. Sunken eyes will become better. So these will be the signs of improving dehydration. When will you suspect that the child is worsening?
If further there will be an increase in heart rate of around 15 beats per minute. If there is overload, respiratory rate will further increase.
How is the bedside bottles?
There will be hepatomegaly.
Hepatomegaly, not hepatomegaly, child will start having puffy eyes. So if you're overloading, child is not able to tolerate those 10 to 12 hours of fluid, then probably look for puffy eyes, or if there is again increasing respiratory rate and heart rate. And engorged jugulas, they say, is one sign. I don't think whether we can see that in a young child. But these, you should not, 10 to 12 hours when the feeds are put, you shouldn't sit in one place. You should also monitor the child, whether the child is going for any fluid overload, whether it is enough or not. Suppose the child hydration status is corrected and has ongoing loss, what will you advise the mother?
Ongoing loss should be corrected with 5 to 10
For this
10 ml
child,
per
for this
kg.
child. Oh, there is one particular thing by WHO amount that you should give for this child.
5 to
For
10
each
ml per
loose stool.
kg per loose stool.
That is your correction, Pa. 10 hours correction is 5 to 10 ml per kg. For less than 2 years, 50 ml for each loose stools. That is the thing that is recommended by WHO. More than 2 years, 100 ml per each loose stool. So even if your hydration status is corrected and the child has ongoing diarrhea, you have to correct the ongoing loss. So that will be dehydration correction. Then
Treat the infection with antibiotics.
what antibiotics will you prefer?
Ampicillin and gentamicin. Ampicillin around 50 milligram per kg per dose, 6 thali, and gentamicin 2.5 milligram per kg per dose in BD dose.
What for 6th hourly? Suspected sepsis.
To treat the infection, yes, sir.
If you have confirmed sepsis, you can go for 6th hourly. Otherwise, you can. The recommendation is 8th hourly. Not necessary to give 6th hourly, right?
Okay, sir.
But I have got an evidence of sepsis. Then you can go for the routine. I am suspecting sepsis. I don't have evidence. You can go 8th hourly, not 6th hourly, right?
I'll treat the infection.
I was asking suddenly if some call came from ministry office. That's why it went off. What is the advice you are going to tell to the mother? How you are going to plan the feeding for this child? F75?
Initially treated with F75 diet.
Why?
For complicated stomach initially.
No, you cannot treat F75 in this child. That is wrong. What is wrong in it? Say, I'll tell you. This child is already consuming some idli, some kanji, something like that. What is the issue in F75? Tell me. How do you make F75?
See, it contains 75 kilocalories. We have 30 ml of milk, 1.5 teaspoon of sugar, and a half teaspoon of coconut oil. Or cereal based, we add 1 teaspoon of sugar and 3/4 teaspoon of powdered puff rice with a half teaspoon of coconut oil.
You are telling everything, conveniently forgotten one thing. What is that?
Milk 30 ml will add, and water to
add
make it
water up to 100 ml.
100 ml.
Suppose 7 kg baby, you are going to give F75 every 3 hours. You are overloading the child. Correct or not?
Okay.
The child is 7 kg. Every 2 hours you give F75 10 times. That means you are going to give 1000 ml. Now only we are talking that we don't want to overload the child. So the F75 is to the child who has not taken anything, who is very moribund and starved. I am starting, then you can go for F75. The child is already practicing with protein, already practicing with idli or kanji or something. You should go for 1.5 to 2 gram per kg of the expected weight and go for it. Okay, what is appetite test?
To test the appetite of the child, usually we use weight into 5, and if the child's weight is around 5 kg, you should give 25 gram of ready-to-use therapeutic food and wait for 2 hours. Make the mother sit in a warm, comfortable environment and ask the mother to give the required amount of food within 2 hours. If the child is able to take the feed fully, then the child's appetite is good and the child has passed the test. If it's
So that
not,
you should tell, the
Very
method. So you should answer your question by telling that I will do an appetite test. I will assess a child's appetite by this method. Then I will decide whether I'm going to give F75, I'm going to directly going for a catch-up diet.
Suppose the
appetite,
appetite test the child has failed. What is your management?
F75.
No, child has failed. Total parenteral nutrition.
TPN.
See, that is the one, whether to go for orogastric feeding or to go for TPN, you are doing appetite test. If the appetite test child has failed, the 5 kg child is not consuming 5 teaspoon of RUTF, ready-to-use therapeutic food, then you will be thinking of, I should give protein in some other form, maybe in the form of total parenteral nutrition. Okay, now the child has passed the appetite test. What is your quality of the food? Tell me.
Sir?
You are going to give something, no? What are the basic denominator? How do you expect the food to be like that? This kind of food should, suppose if you are very sick, what is your mother will give to you?
Kanji.
Kanji. Why your mother is giving kanji, not biryani?
It contains adequate glucose and electrolytes.
Not like that. You don't want to waste your energy by munching the food. The child is already devoid of energy, already devoid of protein. So in that situation, what do you want to do? Kanji, child need not munch, just swallow it. No. So the idea is to protect your existing energy, not to get wasted. So the basic, any nutritionist or any pediatrician, when you are prescribing to the child, there are certain quality of the food you should design. It should be less voluminous. It should be less dense. It should be less viscosity. It should be palatable, and it should be available, and it should be sustainable. That's why we prefer kanji, which is less volume, less viscous, less dense, palatable, easily absorbable, easily available, and sustainable. So these are the qualities any pediatrician should think when you start prescribing MNT, medical nutrition therapy, for this children, right? Okay, that's why we prefer kanji. That's why our CPP kanji sat mixer became a big popular brand, because it is acceptable by the child very easily, because we don't want child to waste energy. You said pallor. You want to give FST for this child?
Not during the initial phase, sir. After the during the rehabilitation phase, initially if we give iron, it will lead to free radical release and E. coli sepsis and also. After the initial phase, I will start iron therapy.
Not only that, for the conversion of iron to ferritin, you
Then
need energy.
Energy will be
Need protein.
consumed.
I don't want to waste my energy and protein in this child. That's why I'm not giving FST in the beginning. And Sam, there will be a defective hemoglobin synthesis also. Even though the ferritin is there, it's not being utilized. So all these three reasons, I don't want to give iron during the start of diet. I want to give during the. When do you start catch-up diet?
Catch-up diet, if the child is gaining weight of around 5 to 10 gram per kg per day with the initial diet, and I'll shift to catch-up diets.
Very good. Good.
How do you make the food energy dense other than adding jaggery and oil? So I was telling you, you should make the food energy dense and easily digestible. Any method?
Fortificate.
Food fortification will give you not energy, vitamins and minerals only. One is thickening the feeds. You were talking about the dilute sambar. No, you should advise the mother to give dal, just dal, which is cooked and seasoned. So one is making the food less dilute. Second is what is amylase rich food?
Potato.
Millets.
What is
Green
amylase?
bananas.
No. So any cereals like rice or pachapairu, whatever, it is soaked and malted and germinated, and it is roasted and ground. So when this powder can be added to whatever the food is the mother is preparing. Suppose she mixes sambar sadam, 1 or 2 teaspoons of amylase rich food, when this powder can be added. So this powder not only increases the micronutrients, it increases the digestibility and makes the food the child to tolerate more amount of food. That is amylase rich food. What is amylase resistant starch?
It's seen in food like green bananas, which can be used in diarrhea, which will decrease the diarrheal episodes.
Okay. So what is that amylase resistant starch? What happens to that starch in green bananas?
It will not be digested and be retained.
It will be retained in the
gut.
See, all the PG should understand that when I am breaking a cereal, that means I am breaking a complex carbohydrate into simple dextrine. That means it is going to augment the calorie, it is going to increase the protein, it is going to reduce the density. That's why Upma and khichdi is a wonderful diet for Sam compared to chapati or idli. Because I am breaking the rice, and when I do so many processes, Madam was talking about amylase rich food, which is more common in Samba Godumai, Samba wheat. What you do now, you moisten it, then you allow it to sprout, then you dry it, then you fry it, then you powder it. So many processes you are doing now. These processes helps it, reduces the density of the child. That's why I always used to tell, puri is lighter than chapati because of the density of the food particle. Chapati is heavier than puri. If you put both them in the weight, you can see because of the density. That's why we are not advising chapati to the SAM children. So always take it in mind, when you break the cereals, it is going to augment the calories and protein. Definitely it will reduce the density. Beginning we told you, no, any food should be already discussed. Okay.
Hello?
Yeah, it's audible. Audible.
Complications. I was asking about complications.
Already, I think she has discussed vitamin A, vitamin D, pneumonia, UT and all. Okay, what is NRC?
Nutritional Rehabilitation Center, sir.
So what is the idea of NRC?
To provide a nutritional supplementation, nutritional counseling,
Inpatient care for SAM children.
inpatient care for babies
Okay.
of malnutrition.
Okay, you have admitted a child. Okay. What is your target weight gain you want to discharge a child? During the time of discharge, what are the things you observe?
The child should lose edema. The child should be gaining weight for around 5 to 10 gram per kg per day for 3 subsequent days. Then child should have a good appetite.
That is for starting the catch-up diet. I'm asking discharge criteria in a SAM child who is admitted with 7 kg in NRC. You are going to discharge a child. So what is the target weight you want to achieve to discharge? During the time of discharge, what are the things you want to observe?
Whether the infection has been treated fully and whether the immunization has been provided appropriate for age.
Target weight target weight.
The
Any
weight for height
percentage?
should
90%
weight for
of
height should
admission weight 15% increase.
15%.
15% increase. அப்புறம் discharge பண்ணும்போது என்னென்ன பாப்பீங்க? என்னென்ன சொல்வீங்க?
Immunization appropriate for age.
என்ன சொல்வீங்க? What will you tell the mother?
Proper hygiene for preparation of food and what sort of food she should give to the babies. Nutritional counseling and follow up.
Nutritional counseling ஒரு broad சொல்லிட்டு நம்ம தப்பிச்சிக்கிறது. யார்
How
கேட்டாலும்.
will you advise complementary
என்ன பண்றதுன்னா, see, when you are discharging the child, first you should notify whether the mother is confident. அதான் NRC criteria. Child weight gain இருக்கு. Mother is confident to identify red flag signs. Mother is confident to prepare F75 or F100. Mother knows everything. That is the discharge criteria. Okay. Suppose if the baby is staying in our hospital, Kanyakumari NRC for 21 days. What is your opinion? What is the expectation of any SAM child?
When will you say failure of treatment?
Or otherwise, I will ask Kanyakumari NRC is functioning well. How can I say it is functioning
The
well?
child still has edema and failed to gain weight of around 5 to gram per kg per day. And
On which day? Say it is failure.
On day 14, day 10, still the child has edema and failure to gain weight of around failure to lose weight, start losing edema by day 4, and there is still edema at day 10, and the child is not gaining weight of around 5 gram per kg per day by day 10.
What will be the probable causes of not gaining weight or failure of weight?
Any failure in nutrition, diet, inadequate diet, improper method of preparation of diet, any untreated infections,
More
any
than that,
coexist
see, you're in the
infections.
hospital, you're teaching the mother to prepare the feed and giving. What can go wrong in the feeding?
Inadequate
What could
feeds.
be missed? What is inadequate? When will the feeds be inadequate? Nighttime feeds. You won't supervise a child during night. So absence of night feeds is one important thing that can happen, which can even kill the child. So you should be very particular to the mother in the initial phase. Feed the child too early. Once you increase the quantity, you can feed the child even 3 early. Okay,
Okay.
so think
Now
about the night feeds.
10 babies in our NRC. Okay, 10 beds, 10 babies, 10 SAM child are there. What is the allowed death rate in your NRC?
Less
Allowed
than
death rate.
5% mortality.
Very good, very good. Less than 5%.
5%.
Okay, when the child goes there and comes for follow-up, when do you say they have defaulted? What is the percentage of children you say there is defaulter? The defaulter rate of an NRC. Again, more than 15% of the children.
So follow-up is very, very important.
Very
You should
important
arrange
in
for
this thing.
follow-up. You should communicate with the VHN or somebody to go and see the child for follow-up. How long will you follow up this child? Any SAM child? Which word? How you manage?
Weight for height comes around 2 standard deviation.
It is good, but what do the guidelines say? Weight for height should reach at least, child should have reached 90% of the weight for height, or the weight comes up 1 standard deviation. Till then, because they will go back to nutritional status, they will falter. As sir was telling, they'll come back to you again with another infection and another SAM. So child has to be followed up. All this has to be done routinely up to till the child has gained 90% of the weight for height. What will you advise about complementary feeds? So suppose the mother gives adequate rice and sambar and reaches up to calories of 800 calories. Is it okay? Wash and dolls, what are the groups that should be included in the complementary? Suppose child goes home.
All sort vegetables, cereals, pulses, everything
Fruits
should
and
be
vegetables. Fruits and vegetables, pulses.
all
Question is-
colors, green, yellow, orange, red.
Question is the food plate, madam is asked. Food
Green,
plate.
all colors, green, yellow,
colours.
orange, red.
Not the colors. Fruits and
Food plate,
vegetables
ma.
should be there.
You have missed the
Cereals
most
should-
important one, ma. Dairy product.
Dairy
Dairy products and fats and oils.
fats.
So the food should contain what percentage should come from fats? The energy should come from fats. What
30.
percentage? 30% konja higher.
Balanced diet.
Balanced diet.
50
What
to
is balanced
55% carbohydrates.
Huh?
3.
What percentage?
Protein 10 to 15%, carbohydrates 50 to 55%, fats
Okay.
30 to 35%.
Okay. So that amount of things should be got from fat also. So fats and oils should be there. Dairy products, animal products, if the custom is allowing that, they should contain cereals, fruits and vegetables, as well as pulses, legumes and nuts. So your diet chart, you can make up a diet chart with only rice and sambar and CPP kanji also, but that is not going to help the child. You should include all the 5 groups in the complementary diet. What about vitamin A in this child?
There is no signs of vitamin A deficiency.
You won't give vitamin A?
We will supplement since the
But this
weight of the
child
baby is
was-
less than 8 kg, but the baby is around 7 months. I'll give 50,000 international units.
Weight of the child
The
is less than 8
take-home
kgs.
message is
How
less
much
than 8
vitamin
kg.
A?
Less than 8 kg, irrespective of the age, I will not give 2 lakhs. That's the take-home message.
1 lakh you should give, not 50,000.
Even 5 years, 7 kg, you can give only 1 lakh. You cannot give 2 lakhs, right? Suppose 8 kg above, you can go for 2 lakhs, irrespective of the age. What is the
Age.
prevalence of SAM in our country? Prevalence of SAM. What is the prevalence in your district, Kanyakumari district? Recently, we did a big survey for the past 1.5 months. Did you come across?
Yes, sir.
Oh, tell me, what is your district SAM surveillance? Kanyakumari. Well, leave alone Kanyakumari. What is the SAM prevalence in the country? What is the SAM prevalence in the state of Tamil Nadu? High or low?
So high.
High. Huh? Our country is 6.3%. The current survey, what we did in the last 1.5 months, we have examined around 9,70,000 children. You know that now? It was
Yes,
going
sir.
on.
Yes, sir.
9,70,000 children. Out of 9,70,000 children, we have detected large number of SAM children also. Okay. Many SAM children are with complication. 45,000 children are being screened for complications also. So our percentage based on the screening comes around almost 10%. 10.2% is prevalence of SAM in the state of Tamil Nadu. Okay. Okay, what are the schemes to prevent SAM antenatally and natally?
Poshan Abhiyan, Anemia Mukt Bharat.
Okay.
Suppose you
ICD,
saw this child as a
ICDS.
normal child. How much?
There are 10 child programs starting from birth to up to 1 year. Can you say 1, 2, 3, 4, 5, 6, 7, 8, 9, 10? 10 programs are there. National programs.
Anemia Mukt Bharat.
1.
ICDS program.
ICDS program no kadiyadu. ICDS is conducting all programs.
Poshan Abhiyan.
Anemia Mukt சொன்னீங்க, right?
Poshan.
Poshan Abhiyan, right? நம்ம நியூபார்ன்ல என்னென்ன program இருக்கு? Did you know about home-based newborn care, home-based
Yes,
young child care, deworming, அப்புறம் IDCF, intensified diarrhea control,
Intensified Diarrhea Control Program.
அது மாதிரி ஒரு 10 program இருக்கு நம்மகிட்ட. அப்புறம் immunization, Mission Indra Dhanush, Poshan Abhiyan, home-based newborn care, home-based infant child care, deworming day, IDCF, immunization. So many programs are there, no? In our this one to prevent child going for malnutrition. Okay. What is the programs was given in antenatal period?
Sir, Anemia Mukt Bharat, Iron and Folic Acid.
நம்ம கவர்மெண்ட் ஆஃப் தமிழ்நாடு என்ன ப்ரோக்ராம் பண்றோம்? குறையதுக்கு
antenatal mothers.
Rashtriya Bal
தமிழ்நாடு கவர்மெண்ட்
RBSK, RKSK எல்லாம் வேறமா. ஆன்டினேட்டல் மதருக்கு நம்ம என்னென்ன ப்ரோக்ராம் பண்றோம்? To prevent
we give any financial assistance.
Janani Shishu Shuraska Karyakram.
JSSK எல்லாம் அது வேறமா. அது வந்து free delivery to the mother and free delivery to the baby. அதெல்லாம் JSSK. ஆன்டினேட்டலா கேக்குறாங்க. இப்ப கவர்மெண்ட் ஆஃப் தமிழ்நாடு என்ன பண்ணிட்டு இருக்கு?
முத்துலட்சுமி ஸ்கீம்.
முத்துலட்சுமி ரெட்டி ஸ்கீம் ஒண்ணு. அப்புறம் முக்கியமா என்ன? Nobody has seen pregnancy kit in your hospital.
But
you have not seen. What are the contents in pregnancy kit? Go tomorrow to your medical college. Okay. Go to the antenatal OP and ask about the pregnancy kit and find out what are the contents are there in the pregnancy kit. என்னென்ன இருக்கு அதுல? பார்க்கலையா? என்னமா நீங்க pregnancy kit பார்க்கலையா? அது one of the flagship program in the whole country. The government, the pregnancy kit எதுல இருந்து வருது? You are telling no Muthulashmi Reddy scheme 18,000. அதுல இருக்கிற 4,000 தான் the pregnancy kit. அதுல என்னென்ன இருக்கலாம்? புரோட்டீன் பவுடர் இருக்கு, டேட்ஸ் இருக்கு, அமுல் நெய் இருக்கு, அயன் அண்ட் ஃபோலிக் ஆசிட் சிரப் இருக்கு. நாளைக்கு போய் பாருங்க. வாட் ஆர் த திங்ஸ் இட் கண்டெயின். ஓகே. பிரெக்னன்சி கிட்ட நம்ம இன்ட்ரோடியூஸ் பண்ணிருக்கோம். இப்போ எல்லா மதர்ஸ்க்கும் நம்ம 6 monthsல கொடுத்துட்டு, பிகாஸ் த பீரியட் ஆஃப் growth occurs in the late third trimester-ன்றதுனால we want to augment the nutrition for the mother. Okay. இப்போ antenatal மதருக்கும் postnatal மதருக்கும் அங்கன்வாடியில என்ன கொடுக்குறாங்க?
Iron and Folic Acid tablets.
அது சும்மா கதை. வேற உணவு
இது
how much calorie, how much protein?
Every day
500
kilograms
kilocalories
of nutrition powder every day.
20 to 25 grams of
720 grams கொடுக்கறாங்க. 720 grams of nutritious powder கொடுக்கறாங்க அம்மாக்கு every day 120. So 6 days க்கு 720 except Sunday. Antenatal-ஆவும் கொடுக்கறாங்க, postnatal-ஆவும் கொடுக்கறாங்க. Antenatal-ஆ கொடுத்து
all this you should tell the mother. Otherwise she might never know that something is given to her also.
So call and tell the program of the state-ங்க. No other state is doing all these things. You should be very proud to see all these programs happening in the village. இல்லையா? Okay. இதெல்லாம் தான் நம்மளுடைய aim to reduce low birth weight babies incidence குறைக்கிறது இதுதான் what are the strategies அப்படின்னா to bring down the low birth weight babies ஓகேவா. What is the incidence of low birth weight babies in our country?
Around
20
5%.
20 to 25%, not 5%. 20 to 25 in Tamil Nadu. Out of 9,70,000 babies, 2,50,000 babies are below 2.5 kg. In spite of pregnancy kit, in spite of Nutritional medicine, in spite of so many programs. That's why today's case discussion is really important for the state. Okay, right.
Did you call back the elder sibling? Did you treat the elder sibling? Instead, the elder sibling was undernourished.
Yes, ma'am.
Okay, that is also part of your treatment. You should call the elder sibling because the best way you can treat is when the child is faltering, not when the child goes in for SAM. And what advice you gave the mother about birth spacing? You asked her to complete the family.
Yes, ma'am. She has already done family planning.
All that should come in your management protocol.
Mm.
Suppose the child is not able to take vitamin A syrup, what will you do?
Injectable form of vitamin A is available, ma'am. 5,000 international units per kg for first 5 days, followed by 25,000 international units for till recovery.
What injectable vitamin A, you will give 5,000 international daily.
International units per kg per day, followed by for 5 days, followed by 25,000 international units till recovery.
Right, should be given daily.
Since it's a water soluble form, there will be no
Okay.
store.
You don't advise like that. I mean, it is water soluble, so it is not stored in the body and it has to be given daily. But in SAM, we don't advise daily. The child will not be able to take vitamin A only if there is severe edema or there's extreme apathy or child is in shock. So only during that period we give injectable vitamin A. Again, you should give 50% of the recommended vitamin A dose even at that time. And then once the child recovers, you have to shift over to the oral vitamin A. So never daily vitamin A in a child with injectable vitamin A in a child with SAM. What are they? Do we have time?
What is 1, 2, 3? What is 1, 2, 3, Sam?
So folic acid will be giving 1 milligram and zinc 2 milligram per kg per day. Then copper 0.2 to 0.3.
Copper.
Sorry,
Iron,
iron 3 milligram per kg per day.
Iron 3 milligram per kg you can give. Can you
What
give
other
the
things?
can you give the constituents of rhizomol?
Constituents, it contains sodium around 40 millimole per liter, potassium 45 millimole per liter, glucose
That's
125 millimole.
ulta. Sodium is 45, potassium is 40.
Potassium 40, glucose 125, fluoride 70, and citrate 7, magnesium 3, zinc 0.3, and copper
Good. 0.03.
0.03.
What is the osmolality?
Sir, it's 300.
Good, very good. 300. Osmolality is 300. Good. Good.
What are the other minerals you will supplement or electrolytes you will supplement?
Potassium 3 to 4 milliequivalents per kg per day. Magnesium 50% max
As
with
what?
0.3
As
ml.
what? How will you give potassium?
Inject potassium syrup.
Potassium syrup. What is the strength?
15 ml, 20 milliequivalents for 15 ml. The syrup contains.
How long
should
is it
give
supplement potassium?
for 2 weeks.
And what else?
Then magnesium injectable on day 1, 50% max self, 0.3 ml per kg on day 1, followed by 0.8 to 1.2 milliequivalents per kg per day for 2 weeks. Then we give zinc 2 milligram per kg per day.
What is the dose of iron you will give this child?
3 milligram per kg per day.
Single dose, double the dose, divided dose, or what?
Since
3 milligram per kg.
BD.
2 divided doses will be the iron. What iron-rich foods you can advise the mother?
Jaggery, dates, offals.
What are the 4 G's? Whatever you say, first we should know what it is and whether the mother can also guide. So what are the 4 G's? So common things first. Jaggery is very good. Dates, okay. Then common vegetarian foods which contain iron. Green leafy vegetables.
Green leafy vegetables.
Vegetables,
Okay.
especially curry leaves and
Curry
minced.
leaves.
So although it is just put away, you should ask the mother to take something like a tokoyal or something which contains high amount of iron. So green leafy vegetables, grains, cereals, grains like what? Ragi,
Ragi.
puri, poha contains lots of iron. And then what else? Actually, dried grapes has good. That is another G. Another is chana. Pulses like chana also contain lots of. Otherwise, non-vegetarian diet also has lots of iron. But try to tell her green leafy vegetables like all this so that she can increase the, or even jaggery or dates to increase the iron content. Okay. Will you deworm this child?
The child is only 7 months, ma'am. Usually we start giving deworming 1 to 2 years. We'll give 200 milligram albendazole. After 2 years, 400 milligram
And at discharge, because a child has breast with recurrent diarrhea, you'll also teach the mother how to prepare ORS, how to give the ORS, how much ORS to give. All this will be another part of management.
Why many mothers fail in their complementary feeding?
Lack of awareness.
What awareness?
How preparation of the complementary feeds. What all diet can be introduced at 7 months.
We are failing in any complementary feeding. No, we are failing. We can say every after 2 patients you see, 1 patient is failing, 1 patient is doing. Almost 50% of the mothers failing. So what we can say that mother fails to attract the child, fails to understand the child's need of the child. Okay, how will you attract a child?
Colorful.
So you want
all
to give
group of colors should be included in the diet.
colorful.
Like
so your Nelson says 2-spoon method. What is it? 2-spoon method. You read the growth and development chapter in Nelson and go to the 6 months to 12 months. No, you are talking about stranger anxiety, object permanence. What is 2-spoon method? Both mother and child should eat from 2 spoons from a single vessel. Allow the mother to eat. The child may spill the food. The child may not eat initially, but still don't get angry and discontinue the process. Allow the child to spill. Then the child one day, maybe on the first day or second day, third day, child will stop taking meat. No? What is schema in feeding? Schema. It is also given in Nelson textbook of pediatrics. Read the growth and development chapter 6 months to 12 months. What is schema? Generally, what the child do? Whenever you give something, child will take in one hand, transfer to the other hand, bang it on the floor, then put it in the mouth. This is what the 4 components. Taking in one hand, transferring to the another hand, bang it on the floor, then put it in the mouth. This is called schema of events. So what child, when you give any food, they put it in the floor. Then suddenly mother rushes and stops the 4th component. After child is going to do, put it in the mouth also. So you should allow the child to practice by his own eating. 2-spoon method should be practiced. Colorful food should be practiced to the child. And overall, child's priority is not eating after 6 months. No, child always wants to explore the surroundings, wants to enjoy the environment. So he may not be liking to eat. That's why those days Nila Chore has come. Our grandmother, they take the baby to the Motamadi, they show the Nila and they feed. Because child's priority is not eating after 6 months. Priority is playing. Okay. So that means child and family should attract the child so that child will not go for malnutrition. Because we have seen in many studies that even though the early initiation of breastfeeding and the exclusive breastfeeding is the contributory factors, 50 to 60% of the SAM I have seen in my clinical practice, especially in ICH, seeing every day around 20 to 35 cases of nutritional cases. We have seen there is a complete failure in the complementary feeding. Many mothers fail to understand the child, what feed the child needs, what is the color food the child should be given. You can see in the OP, child will be only 8 kg for 3 years, going around and playing very actively, but the weight is not there. That means it is not the fault on the child. It is the fault on the mother not to understand the need of the child. So we have seen many parents fail in their complementary feeding, especially in the introduction of complementary feeding and the continuation of complementary feeding. And unfortunately, the first 2 years is going to be the big growth, and we are losing the bus. That's why now we have come with what is called epic 1000-day concept, no? Including the antenatal period, and up to 2 years, we want to concentrate on 1000 days so that we don't lose the, we don't miss the bus. Child will not be a malnourished. Okay. I think Rajendran is looking around. Maybe the time is over. What is okay? Final. How you are going to prevent SAM in the country of India? Tell me.
Dr. Renee, can you stop slide sharing, please?
Yeah.
Okay, sir.
Do you have any plan? Young postgraduate should have a plan, no? What are the plan you want to advise to the Planning Commission and the Government of India that these are the measures we should take to prevent severe acute malnutrition? What is the number one plan you can have?
So proper counseling regarding complementary feeding practices and
Number one plan should be to reduce the prematurity and reduce the low birth weight parents. Correct? Number one priority. Okay. Still, obstetricians are struggling to find out what is the cause for prematurity. As long as we are not coming out of the prematurity, the malnutrition is going to be there, right? So our idea is to reduce. What is Indian Newborn Action Plan? INAP. Indian Newborn Action Plan. Reducing the neonatal mortality to single digit by 2030, reducing the stillbirth by 2030 to single digit. That is called Indian Newborn Action Plan. So our program, the pediatrician should look at obstetricians and look at the antenatal period so that we will not have problem after delivery. Correct? Yes or no? Right.
Yeah. Thank you, sir. It's really excellent presentation from Renee, and as well as excellent case discussion by Dr. Srinivasan sir and Dr. Kalpana. And I request Dr. Rama Chandramohan, please, invite comments. Dr. Rama Chandramohan, madam. Dr. Rama Chandramohan.
Yes, I'm here. I'm trying to put on my video. Excellent. Actually, although it's gone way beyond the time, we didn't even feel the, what shall I say, get bored or get tired. The PG was excellent, Renita, and I think the credit goes to the examiners for bringing out the best in her. Srini and Kalpana, seamless, fantastic it was. You didn't even give 1 minute gap, to or no lull at all. The continuously barrage of questions, and she did an excellent job. I thoroughly enjoyed the session, and fantastic. Thank you.
Thank you, madam. Dr. P. Ram
for us.
Dr. P. Ramchandran, sir, please.
Thank you. It was wonderful, to say the least. First, to congratulate the postgraduate, Dr. Renee, who did a good, very good presentation, and she was able to answer. She was well prepared for most of the questions. So that way it was wonderful. And Dr. Kalpana was asking a very, very the exact type of questions which usually asked in the exam. They actually probe you for the given case, whether you are thinking appropriately instead of having something fixed in mind. Okay, whether you are able to adapt or you are flexible for a child who is given to you on that day, whether you can think and have a real focused approach. So the questions are mainly from Dr. Kalpana on those bases, on those things. And she was able to ask a lot of practical questions, especially in a child with a malnutrition. All the basic things were well covered. Dr. Srinivasan was able to ask very, very basic things. And he was also able to go up to the highest metabolic complexities levels and probe your advanced knowledge. So very practical, what you should know as a basic pediatrician who is going to be working at every corner of the country, I mean, of the state at least. What you should know regarding the child health was extremely well emphasized by him. So this is a very, very important thing which the pediatric postgraduate should know. Unfortunately, this you will never find in any book like Nelson or any such things. You have to keep updated yourself with many of the CME programs and updates which are going on, and whatever the material given in those programs, you should read. And also look at periodic updates of this. Okay. I wish that there is some updates for the postgraduates from ICH and from the NRHM from Dr. Srinivasan, so that they can be kept abreast of all the latest, because some of the programs keep appearing every 6 months or 1 year. They're very dynamic. So you should be aware of it. You should update yourself. And this is a wonderful discussion. I'm very happy for the IAP to have arranged this. I learned a lot. Okay, that is the bottom line. Thank you.
Thank you, sir.
Just 1 second, I would like to thank my teachers because all of them are here. So whatever I know, I learned from them. So thanks a lot to all my teachers.
Thank you, sir. Thank you,
Dr. Janani Shankar, please. Dr. Janani. Dr. Janani, madam, please. I think Dr. Nagalashmi is there. Dr. Nagalashmi. Okay, sir. Srinivasan, sir, final concluding remark.
Which Srinivasan? Jimma Srinivasan or me?
Sir, I was on Srinivasan.
Number Srinivasan, Nandana.
Sir.
Jenny and the team, very nice presentation. Actually, 2 years back, we had a lot of kwashiorkor cases in Kanyakumari district. Around 6 to 7 cases were reported when we are there in Kanyakumari district. We are surprised to see a lot of kwashiorkor. Then we are analyzing why there is a lot of kwashiorkor in Kanyakumari district also. Very nice presentation. All the 3 postgraduates from Kanyakumari. And nice company, Kalpana also has given. Whatever I left, she started. Whatever she left, I started. So it's a continuous process. And I thank IAP for giving this opportunity, especially my pet topic of nutrition I'm talking about. And I thank Rajendran, President, and others, Ramesh Babu, and all others for giving this opportunity. Congratulations, Kanyakumari team, for excellent presentation. And she never get perturbed when he start asking many questions. She was answering really well. That's a good attitude she has. Thank you, Rajat.
So thank you, sir. On behalf of IAP team, I say thank today's chairperson, Dr. Srinivasan, sir, and is as usual excellent, ever enthusiastic person to discuss malnutrition. And thank you, sir. And I thank Dr. Kalpana from that Vellore Medical College who has participated and discussed very well. And I thank all the postgraduates from Kanyakumari Medical College that participating. And I thank Dr. P. Ramchandra sir, Dr. Ramachandra Mohan madam, and Dr. Janani Shankar, Dr. Ramesh, who has participated as judges. Thank you very much. Thank you.